Good day, LU5 students. I'm happy to again be with you and to give this lecture. The title of the lecture is The Use of Clinical Practice Guidelines for Rational Prescribing. This is a lecture in two parts. The subtitle of this lecture is actually Deconstructing Clinical Practice Guidelines, and that's the reason for the figure or the picture in this first slide. So briefly, this is the outline of the lecture. It will have 5 parts, no? 5 bullet points. We'll go through the process of CPG development, and then we'll talk about the structure of CPG so that once you start reading them and applying them, it's easy for you to understand the logic or the organization of practice guidelines. Then we'll talk about their uses and some potential problems. In the second lecture, we'll talk about critical appraisal as well as some examples, applications of practice guidelines, and how to use them in prescribing. And finally, the big picture. So what if we have all of these CPGs? How do we, in fact, use them? So just some trivia regarding practice guidelines. No? In the past, international practice guidelines were organized and found at this particular URL, www.guideline.gov. And this was a good reference because it was a registry or compilation of peer-reviewed practice guidelines. And at that time, when it was still existing, there were more than 2,000 guidelines, and around 150 plus of them were on endocrinology alone. Guidelines have in fact been developed about various health concerns, and you'll be surprised at some of the topics that for which there are practice guidelines. And abroad, guidelines are developed due to sometimes from pressure from the health management organizations or from government insurance, because they would use these practice guidelines as standards, no, to check out if the claims are actually valid. So just to then show you an example, no, in the past, in the National Guideline Clearinghouse that I talked about, which is under the U.S. Department of Health and Human Services, under the Agency for Healthcare Research and Quality, they used to have recommendations, no, about ingrown toenails. And in fact, there was more than one practice guideline on ingrown toenails. No, you'll be surprised. However, this particular reference is no longer available as it was taken down by the U.S. Government because of a lack of federal funding. So alternatively, you can still download some international practice guidelines from Guideline Central. The URL is also here. But for the most part, we typically download practice guidelines from the websites of medical societies, specialty and subspecialty organizations. And you can just search for them on Medline in PubMed or even in Google Scholar, actually. So the guideline development model actually begins, no, when researches, especially maybe randomized controlled trials, are released about a particular issue, no, or a particular health or medical problem. These studies are then disseminated in conferences, published in journals, and this become the substance of guidelines. These guidelines are then developed and hopefully disseminated so that they will make an impact on the medical care as rendered by the practitioner and would make an impact subsequently on patient care. So that's the main point of having practice guidelines. It's really to have an impact on the way that we care for patients. And so if you take a look at the reasons for developing practice guidelines, of course, that's the main reason for improvement of patient care delivered by both the individual doctors as well as groups of doctors, no? Um, such as medical organizations or subspecialty societies for which the guidelines were actually made, no? And so, for example, even in the Philippines, there are many practice guidelines that have been developed to try to guide us in the way that we manage patients. So, for example, in this COVID-19 pandemic, there have been guidance from our Infectious Disease Society, PISMID, no, regarding, for example, the management of COVID, what diagnostics we should be requesting, what is the use of all these diagnostic tests, and even in the return to work, no, of workers to their offices, no, there is also guidance, no, coming from our PSMID. Now, we want to improve patient care, and that's in the context of other strategies for improving the quality of patient care, such as CME activities or even generic strategies in the hospital, like audits or quality care audits, in fact. No? And so CPGs are right along with these strategies. And so very simply, clinical practice guidelines are actually user-friendly statements that bring together the best external evidence and other knowledge or experience necessary for decision making about a specific health problem. So first condition is that it should be user-friendly, easy to read, no, intended for that particular audience and intended for that particular group of doctors to be able to understand it. And it's a combination of both the evidence coming from studies, from literature, as well as also the knowledge and experience of the doctors. And really, CPGs are an integration of the existing research evidence and also the experience or expert opinion of the practitioners. In fact, what's missing here is a third aspect, no, patient values, because in modern CPG development, the major stakeholder who are patients or patient groups are now being considered, no, in the way that we make decisions for their care. So probably in the future we can add plus patients values. So CPGs are really tools for clinicians to bridge the gap, no, between the current practice and their associated outcomes, which are not always the best outcome. And that's why we try to do better. And hopefully, no, following practice recommendations would lead to alternative practices and their associated ideal clinical outcomes. Because again, as I said at the beginning, the end goal of practice guidance is really to improve healthcare delivery to individual patients. Now, in order to come up with practice guidelines, we need to first, no, put together a group of experts, a group of people who will work in the practice guidelines. No? So very important is that first step of organization. Who's going to write it? Who's going to fund it? Who are you going to reach out to? No? And who will be involved in collaboration in developing the practice guideline. After you've identified the groups that will be involved, then you begin to develop the questions, you search the literature, you appraise the literature that you found, and subsequently integrate them, and then give your opinion or systematically give the evidence grade. And then after that, no, give your recommendation after presenting all of your work, no, to a panel of experts. And so consensus building happens. Shall we recommend this? How strongly are we going to recommend it? And then after you've come up with a draft, no, that's disseminated to the public, and then after you have made the final practice guideline, it's then disseminated and implemented. So in fact, it's a tedious series of steps, no, which begins after the organized group, no, has come up with a specific topic. The topic can be broad or it can be very specific, and the panel, no, the expert panel now begins to think about what are the intervention options, no? So let's say for COVID, shall we give an antiviral, remdesivir? Should we give steroids? At the beginning, should we give hydroxychloroquine? Which kinds of patients should we give them to? So you develop the research questions, And for each research question, there may be several outcomes. So let's say for COVID, the outcome might be mortality, it might be the need for respiratory support, it might be length of hospital stay, etc. And so after you've developed all of these concepts, the questions, very specific questions, what is the population, what is the intervention, what are the expected outcomes, then you search and retrieve the literature, you critically appraise them, check their validity, check whether they're applicable to the specific patient group that you're treating. And then because there will be several outcomes, you come up with a summary across these outcomes and then develop evidence-based drafts, which then is presented to a panel of experts and consensus building happens so that you are now with your first draft, which is disseminated to the public in order to modify the final draft for dissemination and implementation. And then you monitor whether it does make an impact on the way that we practice, and then come up again with future questions in the updated practice guideline. And so in terms of the development of CPGs, just a little bit of an elaboration on the steps, who is part of the organization. Of course, there needs to be an admin group. They're the bosses of the practice guideline development. They develop the budget. They decide on the timelines. They decide on who should be engaged in terms of the expert panel or the technical group. And the technical review group or the technical panel is a group of experts on the topic itself. They may also include, for example, experts in clinical epidemiology, in methodology, for them to be able to search, retrieve, and appraise the literature and come up with recommendations. And the expert panel is, I think that's self-explanatory. These are various stakeholders, which have an interest in the practice guideline, either because they're also experts, or they will be using the practice guideline, or they represent groups of doctors or even patient groups, for which the practice guideline might have some impact. Now, again, you identify the topic, can be broad or disease-based, and you do a review of literature to find out what has been done, appraise already available practice guidelines to decide whether you just need to update it in the light of new developments, new researches, and then decide if new guidelines need to be made. After aside from that, you then identify now the specific research questions. Typically, the admin group talks with the technical group to be able to identify these research questions. After the research questions have been finalized, they will now systematically search and retrieve the literature, and then they will do appraisal of the validity and applicability, analyze the study design, and see whether it's in fact applicable to the different types of patients that we see, and the types of treatment you use, and the specific outcomes that you would be expecting. So after that, you already have the literature. You've retrieved them. You will now try to synthesize them. You summarize the results across studies. And typically, after synthesizing the evidence, you decide how good is this evidence, using a standardized scale. And so you do this for each intervention, summarizing the evidence as to whether there is net harm or net benefit, since the literature may be voluminous. And then, after you've already written out the practice recommendations, the specific recommendations, you then invite the experts to consensus building. And so for each intervention, you will decide whether you will recommend or not recommend the interventions, and the panelists would cast their votes regarding the various options. So I think I've already said who are involved here. in modern practice guideline development, we do invite patient groups, no, or representatives of patient groups to participate in consensus building. And then you go to the public forum, and this is the opportunity for other stakeholders to react to the guidelines, and this is the basis for modifications and further voting by the panel members. And so afterwards, we plan the implementation, and then we monitor the implementation and the impact of the practice guideline on the practice of groups of physicians. No? And this is very important because you need to be very clear on your metrics. And so it's actually iterative. No? After you develop it, you disseminate it, and then you monitor whether it makes an impact. And then over time, no, after you've monitored that, you probably need to update the practice guideline as new evidences then come in. So at what step do you think are CPGs most likely to fail or trip up? No? Is it at the organization part? Is it at the development of the statements and recommendations? Okay, it's actually at the last part. Typically, the science is there, the system is there. You're able to organize things, no, so that you can come up with the draft. You're able to publish it. But the problem is the dissemination. We stop at sometimes publishing or making it, and then we fail to disseminate it to the groups of doctors who need to know and who need to learn about the practice recommendations. No? So typically, it's actually the last part, the dissemination, the implementation, as well as the monitoring. No? That's typically where we fail at in the various steps, no, of CPG development. Now, I've talked about how it seems to be very difficult to make practice guidelines. There's so many steps. Excuse me. In fact, there's an alternative method of practice guideline development, and this is the ADAPTE model. So from the term itself, this is guideline adaptation. And the reason why this particular system has been developed is to take advantage of the fact that there are already so many practice guidelines out there. And therefore, you want to reduce the duplication of effort to shorten the amount of time needed for guideline generation. And what happens here is that in the first kind of guideline development, where the questions are de novo, you search for your own studies, the randomized controlled trials, etc. Here, in the adaptive method, what you look for are already published, no, guidelines. And this guideline, these CPGs, are then appraised by a tool called the Agree tool, which is just an appraisal, actually, of how well made the CPG is. Is the rigor in the development, where stakeholders actually considered in the guideline development, and where conflicts of interest actually addressed. So those are some of the questions that are found in the Agree tool. And some of the local examples of practice guidelines, which are adaptation, no, are the osteoporosis practice guideline, diabetes, and the guideline on obstructive sleep apnea in the Philippines. So here is a summary of the adaptive model. So very similar to what I already told you. First, you need to organize and prepare. You also define health questions. But instead of searching for individual literature, you search and screen for guidelines and assess the guidelines. And then you extract the recommendations from these guidelines to see whether they answer your questions, no? And if you have several guideline recommendations, then you synthesize also the evidences coming from this guideline recommendation so that you can develop your own guideline report. So if you're interested in the ADAPTE, no, you can look for their website. This is the URL. And this is they have very good tools, no, which will help you in each step in the guideline development or guideline adaptation. Now, when you begin to read practice guidelines, whether internationally or locally, you will see that many of them are actually following already the so-called grade model. This way of developing practice guidelines is also recommended by the WHO. And for example, the tuberculosis or TB guideline in the Philippines was developed using the GRADE model. GRADE stands for Grading of Recommendation, Assessment, Development, and Evaluation. So this is just a systematic way for us to be able to put together uh, the many studies, no, systematically. Nowadays, it's actually done online, electronically, rather than paper-based. No? Medyo inabutan ko pa kasi yung paper-based, but now it's done electronically. This is to allow guideline developers to be able to very quickly put together various clinical trials into systematic reviews, or even to get systematic reviews, appraise them quickly, and then afterwards come up with the strength of or the level of evidence, how good is the quality of the evidence, and then make recommendations. No, so I know this is very small, but this is how the appraisal and the synthesis of evidence is done systematically in the grade model. And just to show you how it comes out, now, if you have a question, you look for either individual randomized controlled trials or systematic reviews and meta-analysis. If you have several of these studies and several outcomes, then what grade will do, no, the program, will generate an estimate of the effect, no, for each outcome. And then it will be able to then synthesize the evidence and even help you rate the quality of the evidence for each outcome across studies. So automatically, the default is that if you are reading a randomized controlled trial or a systematic review, then it will start with a high rating. And observational studies, on the other hand, have a low quality rating. The rating is modified downwards, meaning a downgrade, no? If the study has certain limitations, imprecision, inconsistency of results across studies, or there's some publication bias or indirectness. And it is, on the other hand, rated upwards, no, an upgrade, if it has a large magnitude of effect and a proven dose response. So I'll show you that in a bit with the examples. And then you're then able to give quality of the evidence, no? And then afterwards decide on the recommendation. Are you going to recommend it for or against? And how strongly are you going to recommend it? Is it a strong recommendation or a weak recommendation based on the quality of the evidence? So let's take a look at the anatomy of guidelines so that when you begin to read the practice guidelines and try to extract the recommendations, especially in deciding on what to prescribe, it will be easier for you. I don't know if you can imagine how many randomized controlled trials have been done before a drug is actually licensed. And if you have a patient in front of you and you're trying to make a decision as to what drug to prescribe, if there are 10 different drugs, these 10 different drugs have maybe tens or hundreds of trials and studies that back them up. And so it's very hard for you to decide. And that's where the practice guidelines will help you. No? So what is the structure of the guidelines? First, typically, there's a question or issue to be followed by a 1 to 2 sentence recommendation. And then what follows is a summary of the evidence and the evidence grade. How good is that evidence? And then based on the evidence grade, there will be the strength of the recommendation. Is it for or against? How strongly are you recommending it? And typically, towards the last part of the guideline will be a comparison with other guidelines or even research directions. So let's take a look at it. No? So there's a question or an issue. The question might be about diagnosis. How do you define the disease? What is urinary tract infection? What is diabetes? What are the criteria? Or what test should you use to verify it? Or in pharmacology, of course, what drugs should I use? Then this is followed by the recommendation, which is 1 or 2 statements which represent already the recommendations of the consensus panel regarding the issue after they have examined the evidence presented by the TRC. So, for example, the recommendation might be we strongly recommend that we use drug X for disease Y. So, this is a strong recommendation. And then that's followed by a summary of the evidence. You need to understand why they're making that recommendation. So there's typically a brief review and synthesis of the available literature, telling the reader whether it's international data, what local data supports it, how valid are the literature that are included, are they consistent across the results, and what are the actual results? Is there a dose response? And how applicable is it to our local patient profile, especially with regards to the patient who's in front of you? And then you need to find out how good is the evidence. So you need to see the evidence grade. Now, this is where the problem is. There is no internationally recognized system yet. Maybe in the future, grade will be the system that everyone will use. But as of the moment, there are many different ways to grade the evidence, no? So some will give numerical ranks where 1 is highest and 5 is the lowest. Others will just give label, good quality evidence, moderate quality, poor quality, or scarce data. And usually the grade is determined by the study design, comparing randomized controlled trial versus maybe case reports, the study validity, what are the biases, no? Consistencies and inconsistencies, and applicability and directness. So here, for example, is the evidence grading of the Oxford Center for EBM and the New Zealand Guidelines group, no? Where the evidence grade 1 is based on randomized controlled trials, and 5 will be expert opinion. The grade quality assessment criteria, as I said, will start off with a high quality for randomized controlled trial. If it's a relatively small randomized controlled trial, maybe it's moderate. And for observational studies, they begin low. And then you lower down the quality of the evidence if there are risks of bias, inconsistencies, indirectness issues, imprecision issues, or publication bias. And you rate higher if the treatment effect is large, there is dose response, confounding has actually been addressed, no? And so these are upgrades. So I just want to show you, I know this is not really very big, but this is one practice guideline that we've developed in the Philippines in terms of, these are the dyslipidemia, this is taken from the dyslipidemia practice guideline. And the clinical question is for persons with diabetes who has had no evidence of atherosclerosis, are statins recommended? That was the question. So the recommendation is yes, statins are recommended for primary prevention of cardiovascular events. And here you can see the quality assessment. These are the outcomes: total mortality, fatal CHD or cardiovascular death, fatal and non-fatal MI, unstable angina, stroke, and acute major CV events. And here you can see the study design were RCTs, no, for all of them. Some had very little data, 1 trial, 3 trials, 4 trials. And then these are the downgrades, no? Is there bias, inconsistencies, indirectness, imprecision, other considerations? So that based on what was here, then you then are able to give the quality of the evidence. So here you can see that most of it is moderate because of problems with indirectness. But here you can see that for acute major CV events, no, it was rated to be high quality evidence because there were no major issues that were seen. No, I think this is just an error, no, non-serious. But again, quality of the evidence is high. And so, after that, the strength of the recommendation is given. How strongly are you recommending it? and this represents the judgment of the consensus panel regarding how forcefully they would make the recommendation based on the evidence that they have reviewed, plus their own experience in their practice. Again, this is the problem. There is no one unified system throughout the world, so that when you begin to read the practice guideline, please make sure to read the introductory pages, the preface, where they tell you how they're able to give the evidence grade and the strength of the recommendation. So it can be represented by letters, it can be represented by actions, do it, don't do it, probably don't do it, or probably do it. No? And there are as many systems as there are many guideline developers, and I know that it can be confusing, it impedes effective communication, and it's even more confusing because some groups actually just put together the strength of the recommendation and the evidence grade in one system. So let's take a look at some examples. Again, this is the New Zealand guidelines group. The way that they do it is grade A, B, C, D in terms of the strength of the recommendation. And if you're given an A recommendation, that means it's based on consistent level 1 studies. And like I said earlier, level 1 studies are randomized controlled trials. And then if it's D, that's based on level 5 evidence, which is probably case series or case reports only. Now, the Canadian Diabetes Association does it differently. There are only 4 levels, but level 1 is divided into 1A and 1B. 1A is systematic reviews and meta-analysis, or large, well-designed RCTs, while level 1B is based on non-randomized clinical trials. Now, the American Diabetes Association, and forgive me if all my examples are endocrine, I am an endocrinologist. They do it differently. It's grade A, B, no? And then recommendation C, and then recommendation E if it's based on expert consensus or clinical experience. While on the other hand, for the gold COPD guidelines, no, they have A, B, C, and then D, no, rather than E, even if D is also panel consensus judgment. So, like I said, many of the practice guidelines that you will read will use the grade system. And in the grade system, it's very simple. Are you for or against? And if you are for, is it strong for that intervention or weak for that intervention? And the opposite in the continuum. So it's fairly easy to understand. No? High quality evidence will typically lead to strong recommendations for that particular intervention. So here, for example, you can see, again, I'm putting back the recommendation for whether you will give statins for primary prevention among persons with diabetes. And you can see that if there are 1, 2, 3, 4, 5, 6 different outcomes, of these 6 outcomes, there's only 1 outcome with a high quality evidence, and the rest is moderate. No? And that's why the recommendation is phrased this way. It is for statins, but it's not strongly for statins, because the quality of the evidence is moderate for 5 out of the 6 different outcomes. And so here also to show you that in grade, you're actually able to check the efficacy, the effectiveness of the intervention, and give the actual effect, no, based on the synthesis of different randomized controlled trials. So here you can see that of the 6 different outcomes, only 4 actually had statistically significant results, and were able to then show you the number needed to treat and the numbers are not very large, no? Although it's only CV events and non-fatal MI, that's 45 and 100, and this is 200. And so this supports the fact that it's not strongly recommended, it's just recommended. So this ends the first part of this lecture. In the second part, we will be giving you some more examples, no? And hopefully that will be very simple for you. I'll also guide you in the expectation for the assignment. It's a very quick assignment, don't worry. And hopefully you'll be able to finish that slide set in less than 30 minutes. So thank you for listening to this first part.